Care of the newborn 5. Post-term newborn. Post-term newborn. Are infant born after 42 weeks of gestation. Post-term newborn are newborn infant born after 42 weeks of gestation. Assessment for a post-term newborn. Hypoglycemia, parchment-like skin, dry and cracked without lanugo. Long fingernails, extended over ends of fingers. Profuse scalp hair, long and thin body. Wasting of fat and muscle in extremities. Meconium staining possibly present on nails and umbilical cord. Meconium staining possibly present on nails and umbilical cord. Intervention for post-term newborn. Provide normal newborn care. Monitor for hypoglycemia. Maintain newborn's temperature. Monitor for meconium aspiration. Small for gestational age. Small for gestational age are newborn who is plotted at or below the 10th percentile on the intrauterine growth curve. Assessment for small for gestational age. Fetal distress. Decreased or elevated body temperature. Physical abnormalities. Hypoglycemia. Signs of polycythemia. Signs of polycythemia are ruddy appearance, cyanosis, jaundice. Remember, signs of polycythemia are ruddy appearance, cyanosis, jaundice. Check for signs of infections, signs of aspiration of meconium. Intervention for small for gestational age. Maintain airway and cardiopulmonary function. Maintain body temperature. Observe for signs of respiratory distress. Monitor for infection and initial measures to prevent sepsis. Monitor blood glucose levels and for signs of hypoglycemia. Initiate early feedings and monitor for signs of aspiration. Provide stimulation such as touch and cuddling and rubbing of the back. Large for gestational age. Large for gestational age are newborn who is plotted at or above the 90th percentile on the intrauterine growth curve. Assessment for large for gestational age. Birth trauma or injury. Respiratory distress. Hypoglycemia. Interventions for large for gestational age. Monitor vital signs and for respiratory distress. Monitor blood glucose levels and for signs of hypoglycemia. Initiate early feedings. Monitor for infection and initiate measures to prevent sepsis. Provide stimulation such as touch and cuddling and rubbing of the back. Respiratory distress syndrome. Remember, respiratory distress syndrome. Description are serious lung disorder caused by immaturity and inability to produce surfactant, resulting in hypoxia and acidosis. Remember, respiratory distress syndrome is a serious lung disorder caused by immaturity and inability to produce surfactant, resulting in hypoxia and acidosis. Assessment of respiratory distress syndrome. Respiratory distress can include tachypnea, nasal flaring, expiratory grunting, muscle wall retractions, seesaw respirations, decreased breath sounds, and apnea. Pallor and cyanosis. Hypothermia. Poor muscle tone. Intervention for respiratory distress syndrome. Monitor color, respiratory rate, and degree of effort in breathing. Maintain airway and cardiopulmonary function and support respirations as prescribed. Monitor arterial blood gases and oxygen saturations as prescribed. Arterial blood gases from umbilical artery. Arterial blood gases from umbilical artery. Monitor arterial blood gases so that oxygen administered to the newborn is at the lowest possible concentration necessary to maintain adequate arterial oxygenation. Any premature newborn who required oxygenation support should be scheduled for an eye examination before discharge to assess for retinal damage. Remember, any premature newborn who required oxygen support should be scheduled for an eye examination before discharge to assess for retinal damage. Suction every 2 hours or more often as necessary. Remember, suction mouth and nasal every 2 hours or more often as necessary. Position the newborn on the side or back with the neck slightly extended. Administer respiratory therapy, percussion, and vibration if as prescribed. Use padded small plastic cup or small oxygen mask for percussion. Use padded electric toothbrush for vibration. Promote nutrition. Support bonding. Prepare parents for short-term or long-term periods of oxygen dependency if necessary. Encourage the mother to pump the breast for future breastfeeding if she so desires. Encourage a much parental participation in the newborn's care as the condition allows. Prepare to administer surfactant replacement therapy installed into the endotracheal tube to a newborn with respiratory distress syndrome. Remember, for a respiratory distress syndrome newborn, prepare to administer surfactant replacement therapy instilled in the endotracheal tube. Meconium aspiration syndrome occurs in terms of post-term newborns. Remember, meconium aspiration syndrome occurs in terms or post-term newborns. Exact etiology is unknown, but the release of meconium into the amniotic fluid is thought to be related to a stressful fetal event initiating a biochemical chain of events. Aspiration can occur in utero or with the first breath. Assessment for a meconium aspiration syndrome. Suctioning must be done immediately after the head. Okay. Assessment for meconium aspiration syndrome. Respiratory distress is present at birth. Tachypnea, cyanosis, retraction, nasal flaring, grunting, crackles, and rhonchi may be present. Remember, rhonchi they sound like snoring patterns of breath sound. Remember, assessment for meconium aspiration syndrome are: respiratory distress is present at birth, tachypnea, cyanosis, retractions, nasal flaring, grunting, crackles, and rhonchi may be present. The newborn's nails, skin, and umbilical cord may be stained a yellow-green color. Interventions for a meconium aspiration syndrome. Suctioning must be done immediately after the head is delivered and before the first breath is taken. Vocal cords should be viewed to see if the airway is clear before stimulation and crying. Newborns with severe meconium aspiration syndrome may benefit from extracorporeal membrane oxygenation. This therapy uses a modified heart-lung machine and provides oxygen to the circulation, allowing the muscle to rest and decreasing pulmonary hypertension and hypoxemia in some conditions such as meconium aspiration. Bronchopulmonary dysplasia. Bronchopulmonary dysplasia. This chronic pulmonary condition affects newborns who have experienced respiratory failure or have been oxygen dependent for more than 28 days. Remember, bronchopulmonary dysplasia is a chronic pulmonary condition that affects newborns who have experienced respiratory failure or have been oxygen dependent for more than 28 days. X-ray findings are abnormal, indicating areas of overinflation and atelectasis. Assessment for bronchopulmonary dysplasia: tachypnea, tachycardia, retractions, nasal flaring, labored breathing, crackles and decreased air movement, occasional expiratory wheezing. Remember, bronchopulmonary dysplasia has occasional expiratory wheezing. Intervention for bronchopulmonary dysplasia: monitor airway and cardiopulmonary function, provide oxygen therapy. Fluid restriction may be prescribed. Medications include surfactant at delivery, diuretics, corticosteroid, and bronchodilators. Transient apnea of the newborn. Transient apnea of the newborn are respiratory condition that results from incomplete reabsorption of fetal lung fluid in full-term newborns. Usually disappears within 24 to 48 hours. Remember, transient tachypnea of the newborn is a respiratory condition that results from incomplete reabsorption of fetal lung fluid in full-term newborns. Usually disappears within 24 to 48 hours. Assessment of transient tachypnea of the newborn are tachypnea, expiratory grunting, retractions, nasal flaring, fluid breath sounds per auscultation, cyanosis. Intervention for transient tachypnea of the newborn: supportive care, oxygen administration. Interventricular hemorrhage. Interventricular hemorrhage are bleeding within the ventricles of the brain. Risk factors include prematurity, respiratory distress syndrome, trauma, and asphyxia. Assessment for intraventricular hemorrhage: diminished or absent Moro reflex, lethargy, apnea, poor feeding, high-pitched shrill cry, seizure activity. Intervention: supportive treatment. Retinopathy of prematurity. Retinopathy of prematurity is a vascular disorder involving gradual replacement of retina by fibrous tissue and blood vessels. Retinopathy of prematurity primarily caused by prematurity and use of supplemental oxygen for more than 30 days. Retinopathy of prematurity is primarily caused by prematurity and use of supplemental oxygen for more than 30 days. Assessment of retinopathy of prematurity is leukocoria. Leukocoria is a white tissue on the retrolental space. Vitreous hemorrhage, myopia, strabismus, cataracts. Check for red reflex. Intervention: laser photocoagulation surgery. Remember, retinopathy of prematurity primarily caused by prematurity and use of supplemental oxygen more than 30 days. Assessment is leukocoria, white tissue on the retrolental space, vitreous hemorrhoids, myopia, strabismus,